43. The child with a GI alteration. Objectives: describe the development of the GI system and its relations to selected congenital defects. Describe the anatomy and physiology of the GI system in an infant and a child. Describe the common diagnostic and screening tests used to detect alterations in GI function. Discuss and demonstrate an understanding of the structural and functional alterations in the GI system. Discuss and demonstrate an understanding of the patho- pathophysiology, etiology, clinical manifestation, diagnostic, evaluation, and therapeutic management of malabsorption and infectious problems affecting the GI system. State expected nursing problems for GI alterations. Use the nursing process to develop nursing care plans and teaching guidelines for the child with GI alterations. Develop home care guidelines for a child with GI alterations. Implement a child and family teaching regarding alterations in the GI system. Develop nursing implications for common medications used with a child having GI alterations. Demonstrate good clinical judgment skills to manage a given patient care situation.
Chapter 43 starts off with covering cleft lip and cleft palate. So these are going to be abnormal openings in the lip and or palate. They can be unilateral or bilateral. Some of the causes can include genetic or environmental factors. The rates are higher with smoking and with binge drinking in the pregnant client. But manifestations for cleft lip, you'll see that the infant will have a notched vermilion border. So that's the little kind of notch on their lip. And a lot of times with cleft lip, there's also dental anomalies associated with it. So they could have malformed or even absent teeth. Cleft palate is where the opening kind of distends into the nasal cavity and even to the uvula, soft, and hard palates. To diagnose cleft lip and cleft palate, if the client had adequate prenatal care, many times we can diagnose it in utero with ultrasound. But if not, or if it's missed on the ultrasound, we'll diagnose it at birth. This is why it's really important when we're doing our baby assessments that, you stick a gloved finger in the infant's mouth and check their palate. So just to make sure everything's intact, that we didn't miss a cleft palate. Management really kind of depends on the severity of it. First thing, we want to make sure we are able to ensure adequate feedings for this baby. They do have special nipples available because it is kind of difficult for them to get that negative pressure to fill in the opening when they're sucking. But it is possible for these babies to breastfeed. Breast tissue is really soft, and so it can kind of fit into that opening in the cleft lip or cleft palate. And what we really want to look out for, too, when the infant's eating is even with appropriate negative pressure, special nipples, proper breastfeeding, breast milk or formula can go through that opening into the nasal cavity and cause the infant to aspirate. So we want to be watching carefully for that as well. The lip surgically can be repaired by 3 to 6 months. The infant may need cosmetic surgery a little bit later on. Palate surgery will be done around 6 to 24 months of age, depending on the degree of deformity. The earlier we can get the palate closed, the better, because that's going to help the infant have better speech development later on. And also, having that opening in their palate puts the infant at risk for chronic ear infection. So we want to close that as soon as we possibly can. Next, we have esophageal atresia with tracheoesophageal fistula. This is where the esophagus terminates before reaching the stomach, and so it ends in kind of a little pouch. And or it could also contain a fistula that also connects the esophagus and the trachea together. The cause of this is unknown, but 90% of infants that are born with an esophageal atresia, or that little pouch, also have tracheoesophageal fistulas. They kind of go together most of the time. We do see it more often in premature babies and in low birth weight babies as well. Signs and symptoms in infants with this disorder. There's going to be a failure to pass a suction catheter or NG tube. So if for whatever reason, we notice the baby's having a lot of secretions, we try and pass an NG tube and set it to suction. We're not going to be able to because the esophagus ends in that little blind pouch. These babies will see excessive oral secretions, vomiting, maybe even a sunken abdominal wall. The three main signs of this are going to be coughing, choking with feeds, and cyanosis. So think 3 C's: coughing, choking with feeds, and cyanosis. To diagnose infants with this, usually a lot of times they have a history of polyhydramnios during pregnancy. So you think normally babies, while they're in utero, they're swallowing amniotic fluid, but these babies, they can't because their esophagus ends in that atresia, or that little pouch. So they tend to accumulate more amniotic fluid in utero. We'll confirm this diagnosis with imaging. Usually it's going to be a contrast medium placed into an NG tube, and we'll document the movement, and we'll see that the medium ends in that blind pouch. A lot of times, babies who have esophageal atresia and tracheoesophageal fistulas, they also have other cardiac and congenital anomalies. So something occurs during development where they just have all of these anomalies together. Management, think positioning. We want to elevate the head of the infant's crib just to help from aspirating on those excessive secretions. We're going to place an NG tube and set it to aspirate every 5 to 10 minutes because we want to keep that proximal pouch of the esophagus clear of secretions. If those secretions accumulate, the infant will have vomiting, they'll start choking, and they'll have aspiration of all those secretions and eventually become cyanotic because of it. We're going to hydrate them, so they'll get IV fluids, and then we're going to give them antibiotics to prevent any sort of pneumonia as well. But really, the main treatment is going to be surgery. We want to get this corrected as quickly as possible with surgery. Next, we have a hiatal hernia. So we're going to talk about a couple different hernias. But with hiatal hernia, this is going to be a protrusion of the stomach through the diaphragm that is not present at birth. It happens afterwards. So these infants usually present with signs and symptoms of vomiting, abdominal pain. They'll have failure to thrive. And then, of course, coughing and wheezing as well. But management is going to be very similar to what we do with reflux. We're going to do position changes, meds if needed, but surgery may or may not always be necessary. It might resolve on its own, so we'll kind of wait and see if surgery is necessary. With a congenital diaphragmatic hernia, this is going to be where the diaphragm fails to close at 10 weeks of gestation in utero. So there's an opening in the diaphragm, and essentially all the abdominal contents kind of herniate into the thoracic cavity through that opening, which results in pulmonary hypertension. The lungs are unable to develop properly in utero, so they'll have hypoplasia of the lungs. You can kind of see in the picture there where the abdominal contents are herniating through. They're taking up so much space, the lung does not have the proper space to be able to grow appropriately. These babies, it's an emergency. These babies have high mortality rates. They require ECMO at birth. Outcomes really kind of depend on the level of pulmonary hypoplasia present at birth. But to diagnose it, we'll hopefully, if they got prenatal care, we're able to see in the fetal ultrasound that there's abdominal organs in the chest. At birth, the infant will have decreased breath sounds on the affected side. And then you may also hear bowel sounds over the chest. And then, of course, they're going to have signs and symptoms of respiratory distress. To manage it, so if we know ahead of time, we'll transfer the pregnant client to a higher level of care because there are a lot of facilities that aren't able to provide ECMO for an infant. I do know that there's some, procedures out there where they're trying to do in utero surgery to help treat congenital diaphragmatic hernias, but that's not kind of widespread either. But again, this baby will be vented. They'll be on ECMO, and as soon as they're stable, they're going to get surgery to fix that hernia in the diaphragm. These babies, when they're going to be vented, they're going to be on a high frequency oscillatory ventilation. So you'll see where their respiratory rate is like 200 to 300 breaths per minute. Just a kind of a little side note too, if a baby is being born with congenital diaphragmatic hernia, we want to make sure the nurses know not to use a face mask or a bag mask for ventilation. It will push air into the stomach. So we want to try and avoid that as much as possible. Next, we have imperforate anus, and so this is going to be incomplete or complete absence of the anus. So signs and symptoms, these infants, they fail to pass meconium stool after birth. So usually if an infant fails to pass meconium, we kind of think it's one of two things, and we either think it's an imperforate anus or Hirschsprung's disease. But either one of those is kind of going to be at the forefront of our minds if they fail to pass meconium. It could be even diagnosed on exam. As shown in the photo, they may have complete absence of the anal rectal canal. With treatment, these babies have issues with anal stenosis, so we'll treat that with repeated dilations of the anal rectal canal. These babies may require colostomy and a bowel pull-through procedure, so we'll want to provide education to parents on post-op care of that, including care of the colostomy, and also educate them that, complete continence may be impossible for these babies. Some other nursing care, we want to make sure, because these babies that are born with an imperforate anus often have other congenital anomalies. So we want to make sure we do a thorough assessment, make sure we look for any dimples in the skin or presence of stool in the urine or vagina, because that could indicate other congenital defects in the urinary system and GI system as well. We're going to try and facilitate bonding between the parents and the infant too. So just trying to provide as much education and comfort for them as possible. With gastroschisis, this is going to be a herniation of the intestines to one side of the umbilical cord, usually the right side, and the viscera is completely outside of the abdominal cavity, and it's not covered by any sort of membrane or sac or anything like that. So these babies with their intestines born on the outside, think about how those intestines are exposed to everything that's in the amniotic fluid. And amniotic fluid is pretty acidic. So a lot of times the intestines are extremely inflamed when these babies are born. And then, of course, babies that are born with this, it's also associated with a lot of other congenital anomalies as well. But to manage it, these babies will get an IV, NG tubes, will cover the intestines with a synthetic material. If there's a large defect, we're going to need to surgically close it after the contents have returned to the abdominal cavity. And usually how we get the contents to return to the cavity, you can see in the photo there, they have something called a silo bag where they cover the intestines, and they use gravity to allow the intestines to kind of just sink back into the abdominal cavity, and then they perform surgery. Um, if this is diagnosed in utero, these babies should be born via C-section. We do not want them born vaginally because there could be a lot of trauma and damage to the exposed intestines. And thinking nursing care wise, if you're caring for a baby that has gastroschisis, I mean, their insides are on the outside and they're exposed to cold temperatures. So thermoregulation is really an issue for these babies. They have a lot of heat loss through those exposed intestines. So we want to make sure we're keeping these babies properly warm. With omphalocele, this is very similar to gastroschisis, in which there's a large herniation of intestines through the umbilical cord. Rather than off to the side, it's going to be through the umbilical cord itself. So the viscera are going to be outside the cavity, but they're going to be covered in a sac. The intestines aren't completely exposed to like amniotic fluid or to anything like that. There's a lot of other anomalies that are associated with babies that are born with omphalocele, so we want to make sure we're assessing newborns for any other congenital anomalies. With this type of disorder, these babies are common. Obstructions are going to be common bowel obstructions, and then sepsis is also going to be an issue for them too. Diagnosis is going to be the same as with gastroschisis. It could be done in utero or afterwards on exam. Again, these babies should be born via C-section if possible. Treatment, NG tube, IV fluids. They'll be receiving TPN, and then eventually surgical correction will be necessary.
The nurse assesses a neonate immediately after birth and suspects a tracheoesophageal fistula, which assessment data would cause the nurse to suspect this defect. An excessive amount of frothy saliva in the mouth. Motility disorders, gastroesophageal reflux disease, GRD, GERD, constipation and encopresis, recurrent abdominal pain, irritable bowel syndrome, IBS.
Quite a bit of this chapter kind of focuses on the treatment and management of GERD in infants. And your book also talks about the difference between gastroesophageal reflux and gastroesophageal reflux disease. So, with gastroesophageal reflux, this is going to be a normal physiologic phenomenon. These babies have painless emesis after meals. Rarely does it occur during sleep. Because it hasn't progressed to like a disease process, these babies don't have failure to thrive. A lot of times, these babies kind of just grow out of it after 3 months or so. And after 18 months of age, 70% of infants are asymptomatic. Usually, with gastroesophageal reflux, meds are going to be completely effective on them. Position changes or even dietary changes. So they could use an amino acid formula, or changing, if they're breastfeeding infants, changing the breastfeeding client's diet to see what causes that reflux. With gastroesophageal reflux disease, so this is going to be where obviously reflux of gastric contents kind of back into the esophagus. Like I said before, periodic reflux is normal, but with GERD, it's going to be more severe and chronic. And these babies typically, their lower esophageal sphincter hasn't quite developed properly. It takes time to develop. So these babies tend to have failure to thrive because they have such frequent reflux of their gastric contents. Obviously, we're worried about aspiration and aspiration pneumonia. It could also lead to recurrent ear infections. They're going to have frequent emesis, abdominal pain. These babies are going to be irritable. They're crying. And pharmacological treatment, position changes can be helpful, but eventually they may even need surgery. Treatment for GERD can include dietary changes. Obviously, we want these babies to have smaller, more frequent feeds. We don't want to be giving them too much formula because they're just going to vomit it back up. There are special formulas out there that are hypoallergenic, amino acid formulas. So trying different formulas to see what is a little more gentle on the infant's GI system. There's Gentleys. If they're breastfeeding, like I mentioned earlier, changing the breastfeeding client's diet, so maybe limiting cow's milk or eggs, those tend to be food items that kind of tend to irritate the GI system of the infant. We could try thickening the infant's feeds with rice cereal. A lot of times, thickening it kind of decreases those episodes of emesis. Position changes, of course, is something easy we can do as a nurse. Now in the hospital, we have pulse oxes, obviously. We can put this baby prone, but always if you put a baby prone, have a pulse ox on them. And educating parents that while prone positioning in the hospital is appropriate because we can watch them more carefully, at home they should be supine, especially if they're sleeping. And if we're carrying the infant, making sure they're kind of in a semi-Fowler's position, a little more upright. We don't want to be carrying them to where their head is lower than their abdomen. If those don't work, we can do medication management. Infants can have PPIs and H2 receptor agonists, so Pepcid, Prilosec. They can have Reglan. If the GERD is not responding to medication management or some of those position changes or food changes, then they may need surgery. And essentially what they do for surgery is they place it's like a 270-degree wrap over the lower esophageal sphincter to increase its tone and decrease the ability of gastric contents to reflux back up into the esophagus. So another issue that's, kind of common in peds is constipation, and on the opposite end, encopresis. This is going to be fecal incontinence. So we'll start with constipation, and then we'll talk about fecal incontinence. So with constipation, for some reason, they don't want to diagnose constipation until the child has had issues for longer than 2 weeks. I feel like that's way too long. If a child has had difficulty having a bowel movement for 2 weeks, they are extremely uncomfortable. Some of the causes could be maybe some changes in diet. So if you think infants, maybe they're trying new foods. If it's foods that aren't agreeing with them or they're having a hard time with, maybe we need to avoid those foods that are causing the constipation. With kids, dehydration always could be a cause of it as well. Maybe lack of exercise or movement. Kids get stressed. Stress can cause constipation too. Or if they're on meds for some other issue, it could cause constipation. And a lot of times if the child has a history of constipation, maybe they have hemorrhoids or fissures, it just kind of compounds and makes the issue worse. But with signs and symptoms, of course, lack of bowel movements, decreased bowel sounds, malaise, nausea, and vomiting. These babies they do not feel good. And then, of course, they could have fissures and hemorrhoids as well. To diagnose it, radiology, history, and patient history. Treatment, depending on the cause and what we find out in the history. So if we note that the diet in particular could be a cause, discussing, more appropriate diets with more roughage, with more fiber, hydration, adding more exercise and movement into the child's routine. Regular toileting. So sometimes children, what they'll do is they don't want to defecate, and so they hold it and hold it and hold it, and their body just keeps pulling water out of their stool, and they become constipated. So making toileting a routine. So, after dinner, let's go. It's your time to go sit on the toilet, have a bowel movement. So having a toileting routine sometimes can help with that. If the child is to the point where they've become disimpacted, then they're going to have to be, admitted and given go lightly until the impaction has cleared. And usually what they do is they'll drink go lightly until they have clear stools. So that as long as that takes, it could be a while. And again, just a lot of education. We could educate the parents on stool softeners and just everything that you would educate on anybody else who has difficulties with constipation. On the other end, we have encopresis. So this is going to be fecal incontinence. So this is usually diagnosed in children that are older than 4 years old. So they're a little bit old enough to have some more control over defecation. And so it's going to be involuntary defecation in children over 4 years old who have normal colon and rectal anatomy. So we want to make sure that there's nothing in this child's history or they're not undiagnosed with some sort of colorectal anatomical issue that could be causing the incontinence. These children, they tend to be really frustrated. Their family's really frustrated. It's embarrassing for these children. So we want to provide that psychosocial care for them as well. Some of the causes, if the child has had recurrent impactions, those impactions start to dilate and enlarge the rectum, and it loses tone. So eventually, once it loses its tone, it can't hold in the stool, and so the child just has involuntary defecation. Maybe the child's had inadequate toilet training. It could be stress. So stress could cause constipation or it could cause encopresis. We do see encopresis. There are a lot higher rates in children that are in lower socioeconomic classes or in children that have diagnosed disabilities or issues with learning. Signs and symptoms, obviously soiled clothing and odor. And a lot of times these children don't even have awareness that it's happened. They could have anal irritation, urinary incontinence, frequent UTIs from all of the fecal incontinence. To diagnose it, just on history, and to treat it, we'll have to help the child retrain their bowel so that they can start recognizing fullness. And so this is where that toileting schedule kind of comes in hand. Like I said, again, we're going to have the child sit on the toilet at this time, recognize their full bowels, have a bowel movement. Trying to decrease stress as much as possible is going to be important for them too. All right, next we have appendicitis. So this is going to be inflammation of the appendix. This is the most common emergency surgery you'll see in kids. Causes, it could be infection, impaction, maybe there's a foreign body or a parasite, and a lot of times we just don't really know what the cause is. A lot of these symptoms that they have are going to be abdominal pain in the right lower quadrant over that McBurney point. So, we'll have the child lay down and then you get your hands and kind of press onto that right lower quadrant. And when you let go, and they have pain in the right lower quadrant. They could also have rousing signs. So where we palpate the left side of the abdomen, but they'll feel pain on the right side of the abdomen. Or they'll have psoas sign, spelled with a P, P-S-O-A-S, psoas sign, where they have pain extending the right leg. Other tricks that I've heard you can do is you can kind of hit the child's heel, and the pressure of hitting their heel, their leg pushes up into their abdomen a little bit. That causes pain. You can have the child try and jump up and down. Most of the time, they're in a lot of pain. They're not going to want to jump up and down. So you kind of know at that point too. We are really worried if the pain stops. If their pain stops, that means the appendix is perforated, and now it's become a real issue. So We want to be keeping out of pain stopped because then we could be worried about sepsis with that. These children will have a fever, they'll have elevated white blood cell counts. We'll diagnose it with a CT scan. Treatment's going to be surgery and IV hydration, of course. If their appendix has ruptured, then we're going to need to give them antibiotics as well.
Obstructive disorders, hypertrophic pyloric stenosis, intussusception, volvulus, Hirschsprung's disease.
With hypertrophic pyloric stenosis, this is going to be where the muscle around the pylorus obstructs gastric emptying. And you can kind of see in that image, there's a thickened muscle of the pylorus, and the stomach's unable to empty contents. The cause is unknown. A lot of times, though, these children have other anomalies of the GI tract. Signs and symptoms, I want you to remember this: progressive projectile vomiting. These kids will vomit like The Exorcist. It's projectile vomiting. These babies are usually greater than 3 weeks of age. A lot of times this vomit can be blood tinged because they have so many episodes of vomiting. On your exam, you'll notice an olive-sized mass in their right upper quadrant, and that's going to be that thickened muscle of the pylorus that you're feeling. These kids, you could see visible peristaltic waves, which is never a good sign. They'll be starving after their feeds, so they'll be vomiting, and then they'll just start crying. They're irritable and they're hungry because they're not retaining anything that they eat. Dehydration and electrolyte imbalance is going to be very common for them. So we can diagnose this on exam. The signs and symptoms. The projectile vomiting is usually part of that. Ultrasound, or sometimes they do barium swallows, but the exam, the signs and symptoms, and the ultrasound are usually enough. Our treatment, we want to correct any fluid and electrolyte imbalances that they have, and then they'll need surgery. The surgery they need is a pylorotomy, and so basically what they do is they'll go in and release that obstruction in the muscle there and kind of thin it out a little bit. Nursing care-wise, just like anyone else who has frequent vomiting, we want to make sure we're providing proper oral care for these babies and these children. They'll need an NG tube, so all the care that comes with that. And then, of course, we want to be watching them for any signs and symptoms of aspiration or respiratory distress just because they are vomiting so much. And that, of course, means making sure that we're putting them in the proper position, with the head of their crib slightly elevated, so that way we're trying to prevent any aspiration. So this is going to be intussusception, and this is where the bowel essentially telescopes inside of itself. So I want you to imagine like you have an extended telescope, and then you compress it back down into its smaller, size, and this is essentially what is happening to the bowel. I put that picture there on the right, so that's kind of what the bowel is doing, where it just kind of slides in on itself. These children, it's extremely painful. They just suddenly start crying. They're flexing their legs. They're in severe pain. They have a sausage-shaped abdominal mass. I want you to remember this. Current jelly stools is going to be the hallmark sign of intussusception. It can lead to sepsis and peritonitis and eventually shock and death. So we want to make sure that we diagnose it and treat it quickly. We can't really wait around to treat this. Some ways that we treat it, we can do a hydrostatic reduction. So essentially they put a catheter into the child's rectum and they fill it with air or water. And all the pressure of that air or water can kind of pop the intestine back out into its normal state. And so it just kind of extends back out like it should. If that's unsuccessful, then they'll need surgery to address it. But nursing care, we want to make sure we're assessing these children's pain. We're providing them comfort. And then obviously we want to treat it quickly because they're in a lot of pain and they can go into sepsis and it can lead to shock and death. With a volvulus, this is going to be the twisting of the child's bowels. And so, of course, this leads to obstruction. It cuts off blood flow to the bowels and eventually leads to necrosis. This is going to be a defect in development. So you'll see a lot of children that have neurologic impairments. They have higher rates um, of a volvulus occurring. Signs and symptoms: extreme pain because they lost blood flow, and then they'll have bilious vomiting. Treatment, of course, is going to be surgery. And then we have Hirschsprung's disease, or you may hear this congenital aganglionic megacolon. So this is going to be an absence of ganglion cells in the rectum. So on the left-hand side of this image, you could see normal rectum has those little ganglion cells. On the right side, their rectum has no ganglion cells. So they're unable to um, sense that need to defecate. This is going to be one of the major causes of obstruction in children. You'll see it more often in children with Down syndrome too. Signs and symptoms is going to be a delay or absence of meconium in newborns. So remember, like I said, if there's a delay or absence of meconium, we're thinking imperforate anus or we're thinking Hirschsprung's disease. If a child has no stool in 48 hours, we're pretty sure it's one of those two. These children also have distension of their abdomen. They're vomiting because they're vomiting. They have this discomfort. They're not eating. They have failure to thrive. They also have issues with chronic constipation. And then definitely remember this: the hallmark sign is going to be ribbon-like stools, and they're foul-smelling stools. We'll diagnose it with a rectal biopsy. So they'll biopsy the rectum and see if there's any ganglion cells present. They could also do a barium enema in older children. Treatment, if they have an impaction, go lightly to relieve that, or surgery to relieve the impaction. They could do surgery to excise those parts of the colon that are missing the ganglion cells. So that could help as well. I've also heard they're doing studies where they can inject Botox into the rectum to help increase its tone, and then therefore increase the child's ability to sense when they need to defecate. One other thing I want to mention that's not on this slide: anytime we're taking any portion of the bowels, so in this case with Hirschsprung's disease, if they're removing parts of the bowels or rectum that are aganglionic or don't have the ganglion cells, or in any of the other GI disorders we talked about, if they're removing part of the intestines, or like you see in children that have necrotizing enterocolitis, where they're removing necrotic portions of the intestines, it can lead to short bowel syndrome or short gut syndrome. And so this is going to be where the child just has frequent diarrhea, foul-smelling stool, increase in gas. They have a poor appetite, malnutrition, lots of bacteria in the intestines. So we want to make sure if there is any sort of surgery where they're removing part of the intestines or rectum, that the provider's preserving as much length of the intestines as they possibly can, because that's going to help them absorb water from the stools. If they're removing large chunks of intestine, they're unable to do that, and they're going to have that frequent watery diarrhea. So just something to kind of keep in mind with surgeries where we're removing part of the intestinal tract.
The nurse is caring for a child with probable intussusception. The child has diarrhea before admission, but while waiting for administration of air pressure to reduce the intussusception, the child passes a normal brown stool. What is the priority nursing action? Notify the physician.